Our second speaker is Sam Harkus, and Sam is a rehabilitative audiologist with Hearing Australia. For a child with early and ongoing hearing loss, it's critical to do something to enable them to hear well and for them to have plenty of daily listening and communication practice. The critical period for this to happen is in the first 3 years of life, and as Kelvin said, in the first year, in fact. There's a gap between how well this happens for Aboriginal and Torres Strait Islander children and for non-Indigenous Australians. The gap is starting to close, but to accelerate this movement, we need to do more and do it differently. And Sam's going to give us some hints as to how this might happen. Thanks, Sam.
Hi, everyone. Good morning. Just trip over the podium. I'm Poche Forum, August 2019. That's the one. Thank you for the introduction, Tom, and thank you to the Poche Centre for inviting me to be part of this fantastic panel. And I would like to acknowledge, of course, everywhere we walk in Australia, we're walking on Aboriginal land. I'd like to acknowledge all Aboriginal people in the room today and pay my respects to elders past, present and emerging. So as Tom said, I'm from Hearing Australia, and if you haven't heard of us, that's because we changed our name a month ago. We used to be Australian Hearing. Is there a mouse? Thank you. Thank you. Great, okay. So just one slide that just sets the context for Hearing Australia. So we're a national organisation, and our aim really is to reduce the impacts of hearing loss for children and for eligible adults who experience that. So that's really a lot around hearing devices and communication support and referrals. We have a network of hearing centres, but we also have a very active outreach program, and I have a lot to do with that. We visit around 230 Islander communities, and we have about 110 audiologists who work in that program. Just to give you an idea of who we're seeing, in the last financial year, we saw around about 6,000 Aboriginal adults. It's interesting that that figure is increasing every year. There are more and more Aboriginal and Torres hearing aid use, which is fantastic. We see about half of them in our hearing centres and half through our outreach program. And for children, we saw about 4,500 last financial year. We see a lot more children in community, fewer in our hearing centres, and around about a third of those children have been fitted with hearing aids. Okay, so these are the key points that I wanted to make in my day. These won't be astonishing to many of you, and Kelvin's already picked quite a few of them in his talk. So that hearing loss relating to the ear infection that so much in Aboriginal is often late remediated, and it has lifelong impacts, and you've just seen some of those. That we actually know what the pathways to care are. We have a fantastic guidelines document, the Otitis Media Guidelines for Aboriginal and Torres Strait Islander children, which lay out the things that we can all do to prevent, identify, treat, manage and refer for Aboriginal kids with ongoing ear disease. But there are multiple barriers that stand in the way to children walking those very sensible evidence-based pathways. Just as Tom said in the introduction, that if we want to close gaps like these, we have to work differently, and we have to work together, and we have to work harder. And that there are, and I'm going to talk about some, just 4 examples of some co-designed approaches that are happening at the moment that will overcome barriers and close gaps in the pathways. Now, I wanted to ground my story, or my talk today, in the story of a woman whose name isn't Christine, but she's a woman that I met when I was doing outreach at the Aboriginal Medical Service in the late 90s. Redfern, and she was transported in from the women's prison to see the ear, nose and throat specialist at Redfern, who's been visiting there fortnightly for a very long time, which is a great service. So she had large holes in both eardrums, almost total perforation, so only fragments of her eardrum left on both sides. And she had moderately severe hearing loss in one ear and severe hearing loss in the other ear. On that day, she was listed for surgery for one of her ears. And after I spoke to her, she decided that if the prison would fund a hearing aid for her, that she would like a hearing aid for the other surgery. And the prison actually did agree to fund the hearing aid, which was fantastic. What was really interesting about her was that she communicated incredibly well, given the level of her hearing loss, moderately severe in her better ear. But in order to do that, she was working incredibly hard to achieve. So the way she sat at the front of her chair, she was leaning forward, she was frowning at me, she was gathering every bit of auditory and verbal information that she could in order to make sense of what I was saying to her. But she was very skilled and experienced at doing that. But you wouldn't know just by looking at her. And in fact, the comments of prison guards later reiterated that a lot of people had no idea that she had such level of hearing loss. So I went out to the prison to visit her for the hearing aid fitting and for the follow-up, and so I learned more about her story as we did this. So she had, not surprisingly, looking at the size of her eardrums and how good her compensation strategies were, had ear disease and hearing loss since childhood. She reflects that there were probably a lot of things going on in her life at the time, but she left school early, partly because she just couldn't hear. Her dream job was to be a doctor's receptionist, but there was a point in her life when she realised that that wasn't a pathway that she could take, because in order to be a doctor's receptionist, you had to be able to hear patients who came up to the counter and wanted to speak discreetly to her about something, rather than having to raise their voice to her and let the whole waiting room know what concerns were. So she closed that off in her mind as her pathway. She had been imprisoned annually since the age of 18. So that was 18 times. The time I saw her was her 18th time. And having read a recent an article that was published a few years earlier by Damien Howard about Aboriginal hearing loss and the criminal justice system, which is a really interesting and still very valid article that talks about how hearing loss interferes with all of the stages: arrest, bail, courtroom processes, etc. So I asked her, how did she manage in a courtroom environment? Because courts are not necessarily acoustically very good. It's stressful, it's reverberant often. You have to be able to hear over a reasonable distance from multiple speakers. And she said that she guessed. So when she was asked a question, she guessed what she was asked, and then she answered accordingly. She attended rehab meetings in the prison, but she couldn't participate because she couldn't hear. And she said that this was the first time that she'd seen an ear, nose and throat specialist or an audiologist. So when I went back for the follow-up, I really didn't know what to expect. What would it be like having a first hearing aid while you were in prison? But Christine had been wearing it regularly, and the change in her was the most overt change was the way she held herself. So she no longer sat forward and concentrated. She could sit back, she looked relaxed, the expression on her face was quite different, and her friends had been commenting on that to her as well. So it was feeding into a more positive sense of self. She could now hear and contribute in rehab meetings, which was fantastic, and she could now talk to her mum on the phone. She hadn't actually commented on not being able to do that, but prison research does talk about hearing loss compounding a sense of isolation in prison. So this was definitely a good thing. She actually went on to become the Koori women's representative at the prison, something she could, which was fantastic and something that she could never have done if she hadn't. And she said, and I'll never forget her saying this, there is nothing better than being able to hear, something we take for granted. So it was a very powerful experience for me, both professionally and personally. It brought to life the issues that Damien had in his article. It opened my eyes about the way that untreated hearing loss to that extent is so disempowering, but the opportunities that open up when you can hear again. And it raised all sorts of questions in my mind, among them, why hadn't Christine mentioned her hearing loss to anyone? And of course, we know all about normalisation of ear health problems and hearing in the community, so that's probably a strong reason. But also, how could her hearing loss be either missed or misinterpreted or not acted upon by the institutions that she was passing in and out of 18 times, so police, corrections and corrections health units. So why do I talk about this? I think it encapsulates many of the issues that still persist, and I think it draws together many of the important themes that we're still thinking about today. So that's the issue of late diagnosis, late remediation of hearing loss, the ongoing normalisation of hearing loss that would be nice to overturn, the impact on life trajectory, that hearing loss disempowers, and that we're still waiting for screening in prisons for at least Aboriginal inmates. And I know this is something that, Paul, you've been active about in WA, but everywhere, in all prisons, in all jurisdictions, hearing loss is a problem for prisoners, and it's a worse problem for Aboriginal prisoners. Okay, so is otitis media really such a problem? This is actually an issue that has been discussed in the broader community, quite a controversial issue, for 30 years. Yes, it's a terrible problem. No, it's maybe not a terrible problem, but this is where the research seems to have landed. So does early and chronic OM affect children's speech, language and communication development? The literature seems to say no, not so much, but only if the child is otherwise healthy, if they don't require amplification and they're not delayed in getting it, and if they're socioeconomically advantaged. Now, the reason why socioeconomic advantage is relevant is because there's a strong relationship between home communication environment, so how much speech and language children get exposed by socioeconomic spectrum, and that's universal across the world. So for many Aboriginal kids, all of these factors can't be assumed to be in place. So yes, OM really is such a problem, but it continues to be viewed through a non-Indigenous settings, including at the policy level. That's a problem. Here is the same graph that Kelvin showed earlier. So Kelvin's already talked about the fact that chronic ear disease, whether it's in urban or can be established by the age of 6 months, and the hearing loss that's associated with it starts very soon after. That first 3 years of life is when all the important cognitive stuff is happening around the development of listening skills and speech and language skills. So you basically have a window of 12 to 24 months to act from the onset of chronic otitis media and hearing loss to the end of that window if you want to maximise the outcomes for that child. So what do we know about hearing loss in the Aboriginal and Torres Strait population, among children in particular? So we know it's overrepresented. So in our cohort of, Hearing Australia looks after almost all the children in Australia who wear hearing aids. So among that cohort, 10% are Aboriginal and Torres Strait Islander, when only 4% of the child population in Australia is Aboriginal and Torres Strait Islander. And we don't even think we're reaching anyone who might benefit from them. So they're definitely overrepresented. We know that the main causes of hearing loss are different between the broader non-Indigenous Australian group and Aboriginal children, which shouldn't be surprising. That's why we're here today. So among Aboriginal kids with hearing aids in our cohort, hearing loss largely relates to ear disease or its complications. And what's really interesting is that Kelvin was talking about the severest form of ear disease, which is when you have discharge coming out of both ears. Glue ear is a less severe form, but that in fact is the main reason why Aboriginal kids are fitted with hearing aids, if you pick one of the etiologies. So 48% of the Aboriginal kids that we see are wearing hearing aids because of glue ear, when in a developed country, you would go along and see your ear, nose and throat specialist, and you would have most likely grommets, and most of the time that's a very successful procedure. Is that right, Kelvin? Yeah. Call me out if I'm straying too much into ENT. All right, we know for non-Indigenous kids in Australia, hearing loss is spread evenly across the socioeconomic spectrum. But for Aboriginal kids, hearing loss is statistically significantly more likely to sit in low socioeconomic areas. And that's, of course, because it relates to chronic ear disease, and chronic ear disease is grounded in the social determinants: housing, nutrition, smoking are probably the key factors. Now, I talked before about having the fantastic guidelines that set out the pathways that children should travel. So we know what they are, but they take much longer to walk than they should. Why? We can guess. There are probably factors like family awareness, normalisation. What does not hearing well actually look like in a 2-year-old? That's actually quite difficult to answer. The ability of primary health to evaluate Bub's ear health and hearing varies enormously. And access to the hearing tests that you need in order to travel those pathways is quite, as Linda was talking about earlier. And also access to ENT, which I know talked about before as well. So one impact of that long time that it takes to walk the pathways is that the age of first fitting of hearing aids for Aboriginal kids is way, way, way later than it should be. So if you look at the graph, that shows 2 time points. So it shows data for 2008, which is the paler blue line, which is, so that represents all the Aboriginal kids who were fitted for the first time with hearing aids that year. And it shows how old they were when they were fitted with hearing aids. So you can see that in 2008, the peak age of first hearing aid fitting was 8 years of age. This is something that across the sector we've been increasingly aware of in the interventions, and a lot of us, us included, but all along the pathway, I think we're understanding more about this. And so what's happening is that is starting to come down. So when we took a snapshot of last year's data, it's now come down to, you can see, somewhere between 4 and 6 years. So it is actually improving. 10 years ago, 1 in 10 Aboriginal kids got their hearing aids, first hearing aid, before they turned 5. Now, last year, it was 1 in 3. So it is really improving, but it really needs to improve a lot more. So on the topic of closing gaps, I did my Masters in Public Health at UNSW and finished it last year. And I remember this light bulb moment in one of my lectures, and I can't remember who, but they were talking about the topic of closing gaps. And so if you have a look at this is just one of the graphs that I pulled out of the closing gap report from a few years ago on mortality rates. You can see how they've set out the graph. There's the the green line, which represents mortality rates for non-Indigenous Australian kids. Then there's a blue dashed line that shows the trajectory that we should be following if we want to close the gap between Aboriginal and kids. And then the red line, or the red dots, I should say, were the stats for Aboriginal child mortality. So if you want to close a gap, any gap, but there's an example of one, if you do the same as you have been doing, that won't work. The gap will actually continue to widen because things continue to improve for the population. If you do what you are doing for the other population, non-Indigenous, that won't work either because the gap will just remain the same. In order to actually close a gap, you have to do better than you are doing for the control population, which means, I'm guessing, doing more of stuff, doing things differently, or joining up and doing things. So I thought I would just pull out 4 examples of projects that are easy to summarise in a slide of that kind of approach that seem to be having results. So Biga Gunbaringu Health Service in Kalgoorlie is doing something very simple. They're linking child ear checks with immunisation visits. So they're targeting 0 to 2-year-olds in the Boulder region and checking their ears every time they come in for immunisations and then acting on And that's a collaborative approach which has involved the community. Another example from WA is something called Ear Portal. So it's an urban project, and the community is linked to an ENT service through telehealth. Previously, they had to wait 2 years for a consultation, but through this program, they're waiting a month, which is fantastic. And it also is a way of linking families to the lab at Telethon Kids, which are doing some really interesting things around whether you can use bacterial therapy to prevent OM, and using a cystic fibrosis drug called Dornase alpha to actually, once you've done surgery, inject that into the ear to try and break down any future glue that might start to build up. So that sounds really interesting as well. We're doing something, we have observed that since the introduction of newborn hearing screening, which is a fantastic world-leading program that's rolled out now in every state and territory, but our sense is that in the primary health setting, because primary health and child health nurses used to be charged with the role, the very important role of picking up hearing loss in young children. Now, since the introduction of newborn hearing screening, our sense is that there's been a loss of expertise in the primary health setting around doing this, around recognising hearing loss in very young children. There's a reliance on family to report their concerns about their child's hearing. So the question, are you concerned about your child's hearing, is one that's commonly asked. But that's a really difficult question for parents to answer unless they know exactly what to look for, what behaviours. So we've done some work, National Acoustic Laboratories, Hearing Australia, and Tharawal and Whirly Whirlinjang Health Service have done some work around co-designing and validating for Aboriginal kids some listening behaviour and language checklists, which basically is designed to help workers in early childhood and primary health settings specifically ask the right questions, score the answers, determine the next steps, and also provide guidance to the family. And then another collaborative piece of work that Deadly Ears and Hearing Australia have been doing is closing that gap between referral, so when Deadly Ears are in a community and they meet a child, a family, and they think the child needs to be referred to us, instead of waiting for our next visit to the community, 3 months away, and losing that momentum, offering the family the choice to do a tele-fit. So most of the time families decide that they would prefer. So what happens is that Deadly Ears go up there pre-prepared with a kit of hearing devices that we've set up for them. They identify the children for referral. The family elects to come in the next day for a tele-outreach appointment. And in that appointment, so there's the family, the Deadly Ears audiologist and our audiologist on the line, bit by video. Our audiologist runs the appointment, but the Deadly Ears audiologist is an active supporter and participant, and it's like a kind of a warm introduction to us. And they're also the hands. So we've trained them what to do with and how to put them on with our guidance on video. And the outcome in those, initially it was 3 participating golf communities in Queensland, but it's now expanded to 6 communities, is a significant shift to earlier hearing aid fitting communities, which is really exciting. And this is one of the little boys. So up the top, in the top slide, that's when he was first fitted. He's wearing a hearing hat, so it's a bone conduction hearing aid built into a baseball cap. And soon after it was fitted, he left it on the bus, and his mum had to chase the bus driver down because he was so upset about not having a hearing hat. And then that's him a year or 2 later, still actively wearing his hearing hat. So now he's at school and he's now wearing his hearing hat every day. So that's a really lovely story. So this circle... 1 minute? Wow, I was so worried I was running over time. Excellent. So this is a conceptualisation of what needs to happen in order to close the gap in ear and hearing health for Aboriginal and Torres Strait Islander children. That central circle is ultimately what we're aiming for. And in the video, the boxing from the Aboriginal Shane, who said that language is the cornerstone of something and culture. I can't remember. I was trying to remember that. Just resonated. So that's the ultimate outcome. The circle immediately around it are the kinds of actions that family and community, it's within their power to enact. Surrounding that are the actions that are potentially outside the sphere of influence of family, but that community or organisations can act on. And then the outermost circle are the macro actions that have to take place at the society and societal and the political levels. So it looks pretty simple, really, doesn't it? The things that I've highlighted in bold are looking back at those 4 projects that we just took a quick snapshot of. I think they're addressing those particular things. And that's it. Thank you.
Okay, any questions of Sam? Comments? Tim, anybody online? A very passive group online. Better turn your phone off, your light.
Sorry, thanks.
You'll run out of battery. One question, Linda had asked about, the data, and you collect a lot of data nationally. How's that, is it a centralised database, or do you report it in any way?
Well, there's a lot of conversation about how for everyone to deposit data into and then to pull data out of, both to inform a lot of things, really. We're a national organisation, so we have a database that up until now has based on, of course, the children and adults that we see and who are aided. So it's not a population-wide data set. But now that's expanding because a year ago, the Department of Health made a surprise budget announcement about a $30 million program aimed specifically at 0 to 5-year-olds, which I think they already have quite a lot of investment going into Aboriginal ways, but I think isolating an amount that specifically looks at 0 to 5-year-olds was a good thing to do. And after a lot of community consultation, Hearing Australia was approached to deliver the program. So now that database is expanding to take in the results of all those children in quite probably what will end up being a large number of remote and regional communities. But it doesn't, that program is remote and regional focused.
So there's no centralised at the moment.
No,
it's just that,
sorry, that was the long...
each state and territory has a cancer registry, and and that's where people can access and understand what the incidence of cancers are. And maybe there's something in the whole hearing area that we need to look at. We absolutely need it, because we cannot actually at the moment say what the prevalence is. We have to look at data like the search study in New South Wales, Queensland, or to get some idea of approximation of population level data, or the child health check data that came out of the territory. And it's all those interventions, like, the government's just having a little bit of early years education, but none of it's ever correlated back to hearing loss and the additional effort that's required at the very early years. So, that's why it becomes really important. Yep, Nikki.
Thank you for your presentation. Nikki Turner, Chairperson of Indigenous Allied Health. I also work for Rural Doctors Network, and I'm one of 5 qualified Aboriginal nutritionists in the country. With the circle where you had the bold area, we can talk about the food, because I think food and nutrition is really important. The other thing is, I'm not sure how much linking we all have with the national peak bodies also, and like I'm involved with the Closing the Gap refresh that Kelvin mentioned. So you've got some good people, well, I think I'm a good person, on that, looking at that refresh and looking at housing. things different to what the targets were. And I think in that there we talk about looking at our Aboriginal people in corrective services and in jails and looking at the hearing loss and hearing problems. I don't know if you can put that in there, but educating corrective services, educating police, educating all these other people that have dealings with our people at that young age also. And I'll call it out, and we need to talk about racism in this. So it's really important. I don't know if you can put that in there, but we need to call it out and talk about that and educating the police, the corrective services, and that about hearing loss. As you said, about no one picked up Christine's hearing loss. I'm sure she said it along the way somewhere, but was it around racism or not? So I thought that, and the trained hearing health workforce within the country, we have less than 1% of our allied health workforce is Indigenous. So we're working at national level around that. I think we've only got a few audiologists. So we've got a long way to go. Three. Yep. So we've got a long way to go with that. But
we do, I agree. I agree with everything you said.
Thank you. I like it when people...
Heaven forbid if you don't. Look at it. And in the declaration of interest, I'm patron of IHAR as well. So, yeah. So any other questions or comments? Well, thank you, Sam, again for your presentation and really bringing light to those issues.